Hello, I'm Dr. Wayne Rosen, and I'm a colon and rectal surgeon and clinical assistant professor of surgery at the University of Calgary in Alberta, Canada. Welcome back to part 2 of this 4-part lecture series on the shortcomings of evidence-based medicine and why it just doesn't work. Now, you may recall in the first lecture, I suggested an analogy between evidence-based medicine and geocentrism, and like geocentrism, I pointed out that EBM has become the dominant paradigm for how to teach, learn, and practice medicine. In fact, there are over 17,000 publications on Amazon which list the phrase evidence-based medicine in their title, and over 156,000 publications which list the phrase evidence-based in their title. Evidence-based medicine is the dominant paradigm in medicine, just as geocentrism was the dominant celestial paradigm prior to Copernicus and Galileo. Before we discuss this further, let me provide some context to this point, and let me say in advance that if you detect echoes of Thomas Kuhn, you are not mistaken. In fact, Guyot and the EBM Working Group in their 1992 Declaration of Evidence-Based Medicine refer explicitly to Kuhn and unabashedly suggest that their approach to teaching the practice of medicine represents a paradigm shift in the true Kuhnian sense. Now, just by way of background, if you are not familiar with Thomas Kuhn and his book, The Structure of Scientific Revolutions, first published in 1962, it is generally considered one of the most seminal and influential books of the 20th century. Regardless whether you agree with Kuhn's views or not, the originality and articulation of his ideas has changed the way that most people think about science and scientific advancement. The contemporary use of the word paradigm and the phrase paradigm shift are testimonies to his profound influence. Now, in any event, while I'm making an argument based loosely on some of Kuhn's ideas, I'm aware that I'm taking some liberty with his notions, so for any purists out there, please accept these as part of the narrative. Now, one of the characteristics of geocentrism as a dominant paradigm, especially of any such overarching dominant theory based on a fundamental misconception, is that it gives rise to peculiar outcomes, inconsistencies, anomalous findings which don't make sense, but which require lots of energy and time to explain. In geocentrism, there were all sorts of inconsistencies in the perceived movements of celestial bodies. For example, the phases of the moon frequently didn't make sense. But because of the overarching assumption, namely that humans and the Earth were the center of the universe and everything revolved around it was so entrenched, scientists of that time had plenty of ways of explaining the peculiar observations. They tweaked the numbers, modified the orbits, etc., etc. And when they couldn't tweak and modify anymore, they simply swept inconsistent findings under the carpet. Like geocentrism, evidence-based medicine has no shortage of peculiar outcomes and anomalous findings, but we have become so inured to the vicissitudes of clinical research and practice that we hardly recognize these anomalies anymore. Almost like this picture, which, until you look at it closely, appears to be normal. I'd like to present a few examples now and have you take a fresh look with new perspective at some old phenomena. And these examples are but a few of the thousands, indeed the tens of thousands of such anomalies. But once you appreciate them, I think you will recognize these sorts of findings everywhere. Let's start here with a study dealing with skin prep and surgical site infection, or what used to be called wound infections. It was published in the New England Journal of Medicine in 2010, and the background to the study is that the standard skin prep for most surgery in North America has been povidone iodine for quite a number of years. This is the tea or brown colored discoloration of the skin that you often see in patients after surgery. A few years back, another solution, chlorhexidine alcohol, began receiving increased attention because there appeared to be fewer infections when it was used as a skin prep for placing central lines. Since chlorhexidine appeared to decrease line infections for central lines, it was surmised that perhaps it would also lead to an overall decrease in surgical site infections in other surgical procedures. But there was one small obstacle, however. The incidence of wound infections after clean surgery, that is, surgery like breast, hernia, hip, knee, and shoulder, is so low, in the neighborhood of 1 to 2%, that it would take an enormous number of patients to have the power to demonstrate a difference in infection rates. So the authors, therefore, chose what is commonly referred to as clean contaminated surgery, where the infection rate is upwards of 10%. You can see it on this table here. The number needed to show a difference would be substantially less with clean contaminated surgery. For those of you who are not familiar with it, Clean contaminated surgery refers to any surgery that involves opening the bowel or transgression of a non-sterile body cavity, such as in gynecology, thoracic surgery, and urology. But the classic example of clean contaminated surgery is a bowel resection, either small or large bowel. The results of the study are quite interesting. You can see here that there was a statistically significant decrease in almost all surgical site infection with the use of chlorhexidine, 9.5% versus 16.1%. And while the absolute numbers are quite small for deep incisional infections, you can see here that there are also significant findings. When you look specifically at abdominal intestinal surgery, you can see that the numbers show similar findings. For colorectal, biliary, small intestine, and gastroesophageal surgery, the risk of surgical site infection is 15.1% versus 22%, 4.6% versus 9.3%, 9.8% versus 29.4%, and 11.5% versus 20.7%, respectively, all in favor of chlorhexidine as skin prep. And if you want to put it in terms of a Kaplan-Meier curve demonstrating statistical significance of these findings, you can see that here as well. The authors conclude that preoperative cleansing of the patient's skin with chlorhexidine alcohol is superior to cleansing with povidone iodine for preventing surgical site infection after clean contaminated surgery. And the authors explain their findings based on a number of factors related to chlorhexidine: more rapid onset of action, persistent activity of chlorhexidine despite exposure to bodily fluids, and the residual effect on the skin. It seems to make sense. Well, that is, until you actually think about it a little bit more. You will recall that the authors chose clean contaminated surgical procedures in the first place, as opposed to clean surgery, because the infection rate with clean surgery is so low. The source of infection in clean surgery is the skin, whereas the source of infections in most contaminated surgery is the unsterile organ, i.e. the colon or small bowel. Hence the 2% versus 10% difference in surgical site infections. Now, if you think about it, you might wonder why the skin prep should make a difference in clean contaminated surgery. The higher infection rate in clean contaminated surgery is not because of the skin flora, but rather because of intestinal contamination. And frankly, it makes no sense for the skin prep to decrease the incidence of surgical site infections so dramatically. I mean, it is like painting your car a cool color and noting an increase in the horsepower. It just doesn't make sense. I've discussed this study with numerous colleagues, almost all of whom concede that there's something a little peculiar about these results, but they attribute the irregularities to minor flaws in the design of the study and normal variations. Even the authors acknowledge that something is a little bit peculiar as well when they write in the final paragraph of the paper, quote, "Overall superior protection afforded by chlorhexidine alcohol was attributed primarily to a reduction in the rates of superficial and deep incisional infections that were caused mostly by gram-positive skin flora." But this still doesn't explain why a skin prep with chlorhexidine should have decreased the wound infection rate so dramatically for clean contaminated surgery. But heck, I guess, if you paint your car cool colors and the horsepower increases, who are we to argue? Now, this is not to imply any sinister motives, but it is interesting to note that chlorhexidine and povidone iodine are both made by Cardinal Health, and that 8 of the 12 authors have financial ties to Cardinal Health. And despite it appearing in such a reputable journal, it's also a bit odd that it's not clear who actually funded this study. As I said, most people assume the somewhat peculiar outcome is related to imperfect application of the methodology of a randomized controlled trial. But I would ask you, the listener, to entertain the notion that perhaps the irregularities in this study are not just the result of imperfect execution of the methodology or related to the vicissitudes of clinical research. I would ask you to consider whether it's possible that there is something inherently problematic about the methodology of an RCT itself, which leads to these peculiar outcomes. Now, let's move on to another example. I'd like to talk briefly about a common condition known as a fistula in ano. Fistulae around the anus have a storied history. It's reported that King Louis XIV of France suffered from one and was so bothered by it that he underwent surgery without anesthesia. His surgeon devised special instruments for the task shown here, and anyone who knows much about fistula surgery will appreciate the challenge of doing it without an anesthetic. The operation was successful, however, and the king was subsequently famous for his toughness and courage. Of note is that Dr. Félix de Tassé, the surgeon, apparently practiced the procedure on 75 commoners prior to operating on the king, and de Tassé received great honors. Incidentally, after his great success on the king, he apparently never operated again. So this anecdote from history may well be the source of two great English expressions. The first, to quit while you're ahead, and the second, it's a royal pain in the you-know-what. In any event, fistulae around the anus are still extremely common and remain a vexing problem for surgeons because of the risk of injury to the sphincter muscle and subsequent possible compromise of fecal control. The management of fistulae remains a perennial topic at colorectal meetings the world over. Over the years, surgeons have developed numerous creative techniques for dealing with fistulae and minimize the risk of injury to the sphincter muscle. In 2006, a surgeon named David Armstrong published a new technique for dealing with fistulae in ano called the fistula plug. It involved putting a plug made of porcine collagen into a fistula tract. This halted the ingress of fecal matter into the fistula tract and functioned as a matrix or scaffolding to permit healing of the fistula tract. Most importantly, it did not involve any damage to the sphincter muscle. Armstrong's original results were quite impressive. I recall watching him present at the American colorectal meeting, revealing a cure rate of around 85%. He had developed the plug in conjunction with a medical device company, and he acknowledged that he held a patent on the plug. Nonetheless, he assured us that it really worked if done properly. His approach seemed to make sense, and over the following years, the technique disseminated widely and was tried by numerous surgeons, myself included. A number of studies were then carried out, and here is a summary I put together in 2011 of approximately the first 25. What I want you to take note of here is that Armstrong's initial results in 2006 show success rates of 83 and 87%. Subsequent studies, however, were not as compelling. You can see the numbers vary widely, and in fact the range goes from 12.5% to 87%, with an average of 50.8% and a mean of 50. It would be hard to get a better distribution. The Safner-Wexner study from 2009 shown here had only 13.9% success, and you can almost hear the sarcasm when they write in their conclusion that further analysis is needed to explain significant differences in outcome. Now, there have been lots of suggestions to explain the variations of these results, such as different types of fistulae, different techniques, different patient populations, and different follow-up, etc., etc. But I would ask you to stop and pause and really consider what a range of 12.5% to 87% means. I mean, those sorts of variations in medical data just tend to glide over us like water. We are so accustomed to them. But stop for a moment and ask yourself what a variation of 700% tells us about this type of research. I mean, where else would you find variations like that? Consider for a moment what it means to tell a patient that there is a 12.5% to 87% chance that they will be cured. For that matter, consider your financial advisor giving you a range like that with regard to your investments. It's hard to imagine other areas of our lives where we encounter variations of 700% and tolerate them, except perhaps when it comes to government accounting practices. Now, we could debate these matters at great length, but I would ask you, as I did before, to consider whether it's possible, just possible, that the discrepancy in these results is not due to techniques or differences in the way the research was carried out, but rather whether it's possible that these results are due to something more fundamental within the methodology of EBM. I would ask you whether it's possible that there is a confounding factor at the heart of the methodology which leads to these disparate outcomes. Now, let's move on to one more example of anomalous outcomes. Here are two studies comparing the sensitivity of optical colonoscopy, that is, regular colonoscopy, and CT colonography, sometimes called virtual colonoscopy, for detecting polyps. The first study on top by Pickert was published in the New England Journal of Medicine, and the study by Cotton in JAMA. Needless to say, both are well-regarded journals. Now, by way of background here, the gold standard for identifying polyps in the colon has always been optical colonoscopy, at least for many years. It allows for direct visualization of the lining of the colon and removal or biopsy of any abnormalities. It has small but real risks associated with it. About 15 years ago, a new technique for imaging the colon was developed, called virtual colonoscopy or CT colonography. It involves insufflating air into the colon via the anus and then carrying out a special CT scan to identify mucosal abnormalities. It still requires a full bowel prep, as it can be quite challenging to tell the difference between stool and a mucosal lesion, but CT colonography has the advantages of being less uncomfortable, not requiring sedation, and has a lower risk of complications. It also allows for sophisticated 3D reconstruction images of the colon. The important question to answer, however, was to know how good it was compared to optical colonoscopy. Specifically, how good was it at detecting polyps in the colon? These two studies were designed to investigate this. Now, assessing whether CT colonography or optical colonoscopy is more accurate is actually quite complex, because there is no way to verify mispathology except by the other method. For example, if a polyp is seen on CT colonography but not on optical colonoscopy, how do we know whether it was missed on the optical colonoscopy or was simply a false finding on the CT colonography? Both papers used a technique called segmental blinding to address this. It isn't perfect, but it's a reasonable way to try to address this problem. In any event, the results from these two studies are shown in this table here. Note that for polyps 10 millimeters in size or greater, Pickert finds a sensitivity of 93.8% for CT colonography versus Cotton's 52% for CT colonography. And for polyps 6 millimeters in size, the differences are even more exaggerated, with Pickert finding a sensitivity of 87.7% versus Cotton's sensitivity of 32%. And for optical colonoscopy, Pickert finds a sensitivity of 87.5% versus Cotton's 96%. You can see here that Pickert finds that CT colonography is about 7% superior to optical colonoscopy, whereas Cotton finds that optical colonoscopy is 85% superior to CT colonography. Pickert concludes that CT colonography as performed by his group is an accurate screening method for detection of colorectal neoplasia and compares favorably with optical colonoscopy in terms of the detection of clinically relevant lesions. Whereas Cotton concludes that CT colonography as performed by his group is not yet ready for widespread clinical application. While these two conclusions are technically not incompatible, the take-home message from both these studies is unmistakable. For Pickert, CT colonography is as good or better than optical colonoscopy and should be widely used clinically, whereas for Cotton, CT colonography is distinctly inferior to optical colonoscopy and should not be used as a screening test. The results and conclusions could hardly be more divergent. Two well-executed studies arriving at really profoundly different results. Within the EBM paradigm, there are many ways to explain this variation in results. There are different quality of CT scanners, variable experience of the radiologists and the colonoscopists, different patient populations, etc., etc. But I suspect that most people would just find it quite illuminating to find out that Pickert, who finds CT colonography superior, is a radiologist and the author of a major textbook on CT colonography, while Cotton, who finds optical colonoscopy vastly superior, is a gastroenterologist and the author of a major textbook in gastrointestinal endoscopy. This is by no means to suggest that either researcher has done anything wrong, but merely to point out that I suspect most people regarding these papers would just find this explanation for the divergent results more illuminating than a whole bunch of detailed analyses of the methodologies and techniques of these papers. I realize that many people looking at these examples will be saying something like, yes, but, and point out specifics in each study and why the results may appear so divergent or peculiar. There are lots of ways you can try to explain this within the confines of EBM. Or you can argue that if you look at these results really closely, they're not that divergent or peculiar. I realize that there are lots of little ways to explain away such discrepant and strange results. But I would ask you, the listener, to take a moment to suspend your objections and to look outside the EBM framework that we all inhabit, and to just entertain for a moment the possibility that there is perhaps a different explanation for such variable, discrepant, divergent, and counterintuitive results. I would ask you to contemplate whether it's possible that there is a more general explanation for why we get such anomalous outcomes. Consider for a moment the believers in geocentrism and the difficulty they had letting go of the notion that the Earth was the center of the universe. There were innumerable peculiar findings and observations, most of which were explained away by tweaking and stretching the framework of geocentrism. And at some point, they just came to accept anomalies in the perceived movements of the celestial bodies as normal variations. But when they suspended their belief in geocentrism and looked at the anomalies again, they had a different understanding of what brought them about. So, as I've said several times before, I am asking you, the listener, to consider for a moment the possibility that the problems I've illustrated here are not due to imperfect application of the EBM methodology, such as flaws in study design or execution, but is it possible that there is a fundamental assumption, a confounding factor, upon which EBM rests, and which leads to these problems? Stay tuned for the answer to this question in Part 3, the fallacy of quantification, coming up next.